Hello, this is Jordan Reese, U.S. Sales Director of 3D Imaging with Carestream Dental. And I'm here with Dr. Shailesh Kottal as part of our Carestream Dental University program. Today, we're going to do a CBCT anatomical review of the mandible. Dr. Kottal, before you begin, I'd like to introduce you. Dr. Shailesh Kottal is an oral and maxillofacial radiologist. He trains at the University of Missouri, Kansas City, and is a clinical assistant professor at the New York University's College of Dentistry, where he operates all advanced imaging services. Dr. Kottal is currently the Director, 3D Imaging for Carestream Dental. Dr. Kottal, welcome, and thank you for taking the time to join me to do this review.
Thank you, Jordan.
Well,
Thank you for having me here.
Thank you. Here we are sitting down with the CS 3D imaging software, and we're looking at our NPR views. I'd like to ask you some questions to do this anatomical review of the mandible. So let me begin. What are the most important anatomical structures in the dental alveolar area?
Jordan, there are, of course, many important structures, but for the sake of a quick Q&A session, I would limit or list out a few structures that are absolutely important while reviewing a scan. In mandible, or just as in any bone, a few things to be noted. Number one is the cortical bone. The cortical bone by itself acts as the margin of the mandible. Now, if you notice, the cortical bone, as in the cursor indicates, the cortical bone is thick, it is pretty prominent, and forms as the margin of the mandible. And then you can look at the cancellous bone. The cancellous bone is encased into the cortical bone, which is the interior part of the mandible, or any bone for that matter. And that also shows the pliability of the bone, the density of the bone, and things like that. The trabeculation pattern, which also indicates many different conditions of the bone. Since the traditional way of examining the bone density cannot be applied to CBCT, it is imperative to go through all these three different types of, or for lack of better words, types of bone or different parts of bone to understand a certain pattern in which how the bone could look different between from one side to another or between two different individuals.
Thank you very much. And I think I should have introduced this as being a cursory overview of the mandible. This is not a full radiology read. We're looking with the Carestream University to do short videos that cover important areas critical to cone beam CT, but to do them in brief online presentations. So in summary of what you were saying, to go back to it, number one was integrity of the cortical bone. Number two was structure of the cancellous bone. And number three was the trabeculation pattern. What other anatomical structures, if any, do you focus in on?
To pick up from the previous question, yes, that is absolutely correct. Those are the three things to start with. And of course, as we expand the horizon into interpreting or going through the images, few things to look for. Number one, inferior alveolar nerve canal. Now, everyone knows that that's one of the most critical structures that exists in the mandible. So identifying the inferior alveolar nerve canal, identifying the course of the inferior alveolar nerve canal is very important. And then you go to identifying the foramens, the mandibular foramen through which the inferior alveolar nerve canal exits. It is also a very important structure. As you can see, it is very prominent, hard to miss. It is typically located around the premolar region. So one of the very critical structures to be evaluated. Now, besides the mandibular foramen, we should also remember that we do have a lingual foramen that is ideally located around the junior tubercle, which is in the midline area between the two central incisors, as demonstrated. Right now, you can see it as a little hole. The sublingual, the lingual foramen opens into the sublingual space, so that is also a critical structure to be evaluated. So all in all, starting from cortical bone up to lingual foramen are all critical structures that needs to be, that definitely needs to be, I would say, I would emphasize on that, that has to be visualized and interpreted.
So I see now that you are focusing in on the MPR views, and here you are demonstrating the nerve canal.
That is correct. That's a very good view of the nerve canal. If you look at that, you can see the cortical structure of the nerve canal, the superior border, the inferior border, the nice encased structure of the canal, and that is a very definitive way to analyze if a canal, if the borders of the canal are intact, what is their relationship to the other anatomical structures close to it, and how they can change in shape or in terms of morphology as you go through the same canal on the same side.
And then if we move more anterior, if you would demonstrate where you find the mental foramen, I think that would be very helpful for those viewing our presentation.
That spot, what you see there, is the mental foramen, and it is very evident. It is very hard to miss. There are very seldom cases in which you cannot see the mental foramen. Even if you're not able to visualize the inferior alveolar nerve canal, you will be able to visualize the mental foramen, which should give you a very conservative idea of location of the inferior alveolar nerve. So the mental foramen, one of the key structures to be noted around the premolar area, very prominently visible. Just like as you see over there, you'd see a clear separation from the inferior and the superior aspect.
Excellent.
I think that should explain that.
You mentioned the lingual foramen. If you would, I believe we'd find the lingual foramen right in the midline in the mandible. If you could show us that also.
That is very, very well noted. Let me just scroll around and get to the exact view. That would show the lingual foramen. If you notice, it's just like the name implies. It is on the lingual, it's on the lingual surface, and that's where it is.
Excellent. Well, I see in the software that you're denoting the L for lingual, and we're seeing that right there in the midline. If you don't mind, could you zoom in on the curvilinear view so we can see? There we go. Thanks. That we're right there in the midline of the patient. So the inferior alveolar nerve, the mandibular foramen, and the lingual foramen. What are the important features of the mandible to be evaluated while planning for implant surgery?
That is a very good question, Jordan. It emphasizes, your question actually leads to one of the most important things, that when we analyze any kind of anatomy, it may not be just limited to the critical structures. There might be few other things that can potentially give you an idea about how the surgery has to move. And one of the, or a few things to be noted, and I have to emphasize that it is not limited to what I say over here, but the common things to be noted in terms of implants is, number one, the angulation of the ridge. The angulation of the ridge would give you an idea of how the ridge is in relation to the opposing dentition. Now, now, how does it help you in terms of implant evaluation? In cases where loading of the implant becomes critical, especially in the posterior area, it is good to identify that angulation of the ridge to change any kind of angulation that is needed in the surgical procedure. Now, once the angulation of the ridge has been analyzed, and I again emphasize it does not necessarily have to be in this order, you have to critically also view the morphology of the ridge. So the morphology of the ridge is nothing but you have to identify all the borders of the ridge, and as you all know very well, that borders can change. The shape of the morphology of the ridge can change, especially the crestal bone. If you look over there to see how the crestal bone is not exactly in a linear plane. It is curved, and that could easily change as you move from one slice to another or from one location to another. And you also need to know that area to be able to identify how much length and breadth of the implant that is to be placed in that particular region. Now, beyond that, you you also have to look at the lingual undercut. Now, every human being, all of us do have some sort of lingual undercut to some degree. Now, is it a very critical finding? Probably not. But in terms of implants, it is important to note, as you notice, that there's a slight thinning of the cortical bone there. And about all that, if that was an edentulous area, you have to also make sure that you do not perforate while placing an implant. The length of the implant does not go beyond the lingual undercut so that you perforate into the soft tissue. So those are the three important things: the angulation of the ridge, the lingual undercut, and the morphology of the ridge.
Excellent. Thank you very much. So are there other relevant structures that have to be evaluated in this time now for endodontic purposes?
That's a good question. So as an extension to the previous answer, now once all those things are evaluated, now maybe the angulation of the ridge, the lingual undercut, and the morphology of the ridge has nothing to do with endodontics, but the inferior alveolar nerve and the foramen does have a critical role to play. Now, specifically to endodontics, canals. Why do we scan a patient for endodontics? To identify what, the radicular anatomy. So the canals itself has to be evaluated. It's right from the pulpal horns to the apex, the apical, to the opening of the apex. You can clearly see that it has a good value in actually adding the third dimension to visualizing the canals. You can also visualize it if you look at the axial structures where you see the pulpal horn. If there are any missing canals, you can identify calcified canals or even calcifications within the canal, certain isolated calcifications, pulp stones, or various other things. And
so,
at the apex of the teeth, I'm sorry.
Go ahead.
At the apex of the teeth, it is also important to identify the relationship of the apex of the teeth in terms of canal. What do I mean by that? I am trying to, I would be trying to assess how far or how close I to in relation to the apex of the tooth and the inferior alveolar nerve canal, because that space is important while doing surgical procedures.
Excellent. So radicular anatomy and proximity of the apex of the teeth to the nerve canal. These are very important. Now, I understand dentists are interested in visualizing the PDL and PDL-related structures. So which are the most common non-implant related findings commonly visualized in scans of the mandible?
So those are two parts of the question. I'm going to take the first part first, which is about the PDL. So one of the limitations of CBCT is that it cannot see soft tissue structures, and it should be duly noted that you will not be able to visualize the PDL as such, just like in any other radiograph. What we are able to see is the PDL space. Now, if you're looking at the PDL space, you can check for the integrity of the periodontal space, the lamina dura, and any breaks in the lamina dura that you can see in the apical region, which could imply diseased tooth. So you are able to visualize that area and able to identify if there's any changes in the shape of the PDL space and the lamina dura and its relationship to other anatomical structures. Now, coming to the second part of the question, the non-dental related findings. Now, there are many findings that you can find or you can possibly see, but a few common things that you're able to visualize on a mandibular scan. Now, I have to again point out, now in this view, you're also seeing a very limited amount of mandible, but let me point out that the things that you can see in possibly these are actually siloliths, which is nothing but salivary gland calcifications of all the major salivary glands. You could see parotid gland calcification, submandibular gland or ductal calcification, and same with the sublingual as well. Now, calcified lingual tonsils are very commonly visualized. Not a very serious finding unless there's some history to it, but can also be visualized in a different view. Calcifications in the thyroid can also be visualized. And on a more serious note, carotid arthromas in a slightly larger field of view where you can capture up to the angle of the mandible and the ramus and the ascending ramus of the mandible, you would possibly be able to see even carotid arthromas if they are present. And it should be also noted that carotid arthromas can or may be visualized even on a two-dimensional panoramic and not just on a three-dimensional scan that you see.
Well, as you mentioned, not all of these findings can be found on this 8100 3D scan, which is our dual jaw 8x9 scan. What would you say would be the benefit of capturing a smaller field of view scan, such as this 8x9, or similar to just capturing an 8x5 single jaw scan?
Well, very good question. It comes down to saving a lot of radiation to the patient. As we all know, radiation is a cumulative factor and not an individual factor. So by limiting the field of view, we expose the patient to only the necessary amount of radiation that is needed to achieve diagnostic results. Secondly, you don't expose larger structures, so since your view is limited to dental alveolar structures, you also have to, or you're only exposed to those areas which you're comfortable interpreting.
Interesting. So going back to all these findings that you have mentioned, is it important to note these findings, and if so, why?
Oh, that comes to essentially bookkeeping, and that's a very good question. It is important. Once you see a finding, it is important, just like anything else, it is important to note them in the patient chart because it shows that you have interpreted the scan, you have noted the findings, just like how you do it on a two-dimensional radiograph. And it's a process of bookkeeping and also for medical legal reasons.
And if a clinician cannot identify a finding, what would you personally suggest would be what they should do or their next steps?
That is a good question. If there are findings that cannot be identified by a clinician and it might be beyond the scope of their practice, I strongly and personally recommend to take expert advice on those from whoever is available nearest to you or whoever is known to you.
So from what I'm getting, the clinician should note not just the pathological findings. They need to input these into a chart to record that the scan was actually evaluated. And if they're finding something in the scan that they're not confident of a diagnosis, they should look to an expert for those. Dr. Kottal, I do have one more question for you. I often get asked the question when dealing with a clinician who may not have a cone beam in-house. They ask me, do I have to scan the mandible if the panoramic view, the panoramic 2D radiograph, shows all the anatomy that is needed for implants? How would you comment?
Well, the answer to that question is a little more than just one sentence. So if you visualize, when you visualize anatomy and when you look at a two-dimensional radiograph, let's not forget that a two-dimensional radiograph is nothing but a two-dimensional representation of three-dimensional anatomy, which means that one of the dimensions is missing. Now, that dimension is the depth. Now, the depth in this case translates to, if you directly compare between a two-dimensional radiograph or a panoramic radiograph to a three-dimensional scan, that relates to buccal lingual anatomy, which is essentially the depth. Now, as you can see in the cross-sectional over here, and that is one of the things that I want to mention, that there's no other way you can get a cross-sectional view other than doing a three-dimensional scan or by surgically exploring the area, which is not possible all the time. So for that reason, you have to, whenever you need a scan in which cross-sectional anatomy has to be visualized, it is absolutely imperative to do a three-dimensional scan.
Excellent. Well, this is very helpful. I really appreciate your time, and I know that those who will watch this in the future are really going to benefit from your opinion, your candor, and the time you spent showing us how to do an anatomical review of the mandible. I do want to restate that this was a cursory overview, not a complete overview of the scan, not a read, but a very quick overview to give us a good idea of the important structures, when to look at which structures, how to focus in on those specific to a task, and what to do in terms of recording findings, that it is imperative to place those into the chart. That concludes for me this portion of Carestream University. I would like to continue to thank you for adding in my contact information. My name is Jordan Reese. I'm the U.S. Sales Director of 3D Imaging. If you want to gather more information, please visit us at carestreamdental.com. We have lots of helpful education. And if you have any questions for me, of course, please do feel free to reach out to me directly. Dr. Kottal, again, thank you so much for your time. We really appreciate it, and I look very much forward to recording another session with you. Hopefully next time we can cover the maxilla.